Welcome to Roadmap to Residency. Hello everyone, I'm Abhiraz. Welcome to our Talk to 50 Matchmaker sessions. We are currently in our psychiatry module. We will be running through some questions with you guys to help you on a journey to a 250. Now this video is all about bipolar disorders. Now, like I have told you in the previous epilepsy videos, same thing happens with the psychiatry one. So what I want to tell you is that in psychiatry, they don't want you or they don't generally test you on diagnosis, but they do test you on the psychopharmacology part. Okay, how do you treat this disorder, sort of things? What are the side effects of the drugs? How will you treat the side effects of the drugs? Now, that is there are few things that are generally tested in the USMLE step one examination rather than the straightforward diagnosis. So here we have which of the following is the most likely culprit drug. So a 36-year-old woman comes to the office for follow-up of mood disorder. The patient has a history of several depressive episodes that started in her 20s. 2 years ago, she was hospitalized after staying up for several nights without sleeping and claiming that she had special powers to end global poverty and climate change. So maybe the patient is having some manic symptoms. Her symptoms responded well to treatment, and she has remained on the same drug regimen since then. However, the patient now has new onset constipation, dry skin, and hair loss. She is also concerned about a weight gain of 2.27 kg over the last 3 to 4 months, despite eating healthy, low-calorie foods. Blood pressure is written upon 70 and pulse is 55. The patient appears tired, but physical examination is otherwise normal. The diagnosis is established and her current condition is attributed to adverse effect from one of her medication. Which of the following is the most likely culprit drug? Now, just like I told you, this question is wanting you to diagnose the patient. What was the drug that was given for the patient for the acute episode, and what is the side effect of that drug, and which drug is causing all these things. So they have given you the side effect. They have given you the hint that some drug is being used for the symptoms. Now, according to the side effect, which may be the culprit drug? Carbamazepine, citalopram, clozapine, clozapine, lamotrigine, lithium, or risperidone. Now, these are some of the mood stabilizers that are used in the bipolar disorder. So lithium are used in the manic and depressive episodes, which can cause diabetes insipidus, hypothyroidism, tremor, abstinence anomaly. Valproate are used in manic features and can cause hepatotoxicity and neural tube defects. Carbamazepine are used in manic features and can cause aplastic anemia, SIADS, and neural tube defects. Lamotrigine can be used in depressive features and can cause adverse events like Benan-Ras and Stevens-Johnson syndrome. These patients' weight gain, hair loss, and mild bradycardia are most likely due to the lithium-induced hypothyroidism. Now, lithium is a mood stabilizer primarily used in the treatment of bipolar disorder. It can cause hypothyroidism by interfering with normal synthesis and release of thyroid hormone. The compensatory increase in the TSS release by the pituitary can lead to goiter in some patients. Now, lithium-induced hypothyroidism is treated with standard levothyroxine replacement and does not require discontinuation of lithium therapy. Now, long-term lithium therapy is also associated with adverse effects of renal function. Example, nephrogenic diabetes insipidus, chronic tubulointerstitial nephropathy requiring regular monitoring of blood lithium levels and renal function. Blood urea nitrogen and creatinine. Lithium used during pregnancy has been associated with abstinence anomalies of the tricuspid valve, but the absolute risk is small. Now, long-term lithium therapy can give you GI symptoms as well as CNS symptoms. So whenever you can see the patient is having some psychiatric disease, some drug have been used, and now the patient is having GI and CNS symptoms, okay, then you can think that the patient may be started upon lithium, okay. Also, the monitoring of lithium is very, very important. Okay, you need to monitor the blood lithium levels and renal function. Now, this beautiful figure is from Foster and typically explains everything about the mood disorder and how you can effectively remember the mood disorder. So first, let's go over the text. So mood disorder is characterized by an abnormal range of moods or internal emotional states and loss of control over them. Severity of moods causes distress and impairment in the social and occupational functioning, includes major depressive disorder, bipolar, dysthymic, and cyclothymic disorder. Now, episodic superimpose psychotic features, for example, delusions, hallucinations, disorganized speech or behavior, may be present at any time during mood episodes other than hypomania. Now, this is how you diagnose different sort of mood disorders. Okay, but if you can just remember this flow chart, then it will be a cakewalk for you. So we have some symptoms like mania, hypomania, euthymia. This is normal mood, dysthymia, and depression. Now, in major depressive episode, what happens is that you are depressed. Okay, that is the one thing that you have. You may have dysthymia, or you may have a depressed mood. But in addition to the depression, if you have the psychotic features, then you will be labeled as MDE with psychotic features. Now, talking about the bipolar disorder, okay, bipolar one, okay. Now, bipolar means that you will have a variability of the mood. Okay, that is the definition of bipolar. Okay, bipolar, two different moods, okay, occurring at some interval. Now, you may have sometimes elevated mood, or you may have sometimes depressed mood. Okay, now you may have sometimes elevated mood and you may be a manic. Okay, the person may be manic. Okay, now that is called as the manic episode. Now in manic episode, some psychotic features may be possible. Okay, now that this is when you have so much elated mood. Okay, and if the person is having a depressive mood, okay, now that is a second sort of mood. Okay, second sort of bipolar mood. Now in a depressive episodes, okay, if the person is only having dysthymia, the person will not be having psychotic features, or if the person is having hypomania, the person will not be having psychotic features. But if the person is having mania, or if the person is having depression episode, then psychotic features may develop. Now this is called as bipolar 1. Okay, now the thing with bipolar 2 is that the person will not generally have a manic symptoms, but they generally have a hypomanic symptoms. Okay, hypomanic symptoms in addition to variability with depressive symptoms, and the manic features only appear in the depressive symptoms, but not in the hypomanic symptoms. So how to differentiate bipolar 1 and 2 is that psychotic features may be present either in the elated mood or in the depressed mood. But in the bipolar 2, the psychotic features are only present in the depressed mood. Now, another is this schizoaffective disorder is when the psychosis overlap with mood episodes, but most occur by itself for more than 2 weeks. Now, schizophrenia and schizoaffective episodes we will discuss in some other video, but for now, I want you to remember about this bipolar 1 and bipolar 2. Now, talking about the bipolar disorder, bipolar 1 requires one type of episode, that is more than one manic episode plus minus a hypomanic or depressive episodes, may be separated by any length of time. Like I have told you, a variable length of time. Bipolar 2 requires two types of episodes, a hypomanic and a depressive episodes with no history of manic episodes. Like I have told you, there is no mania in case of bipolar 2. Okay, there's only hypomanic episodes. Patient's mood and functioning usually normalize between the episodes. The use of antidepressants can destabilize the mood, and there is high suicide risk in case of bipolar disorder. The treatment may be due to mood stabilizers, example lithium, valproate, carbamazepine, and lamotrigine, and atypical antipsychotics. Talking about the cyclothymic disorder, which is the milder form of bipolar disorder, fluctuating between the mild depressive and hypomanic symptoms, most last more than 2 years, with symptoms persistent at least half of the time, with any remission lasting in less than 2 months. Now, let's do one more question here. Which of the following medication is the most appropriate agent for the long-term management of the patient? A 27-year-old man is brought to the emergency department by his wife. She says that he has been acting crazy for the last 2 weeks. He has hardly slept for the past 7 days, and instead has worked on miscellaneous projects around the house. The patient spent several $1,000s on new power tools to accomplish these tasks. When questioned, his speech is rapid and frenzied. He feels spectacular and is creating an architectural masterpiece. The patient has had two previous depressive episodes. Now, which of the following medication is the most appropriate agent for long-term management in this patient? Remember, the question is not asking you about the acute management. So the person is now having a manic episode. Okay, the person has previous two depressive episodes. So this may be a case of bipolar disorder. Now, which we talk may be used for the long-term management: bupropion, chlorpromazine, haloperidol, lorazepam, paroxetine, and valproate. This patient's euphoric mood, decreased need for sleep, hyperactivity, grandiosity, and pressure speech lasting more than a week are characteristic of an acute manic episode of bipolar disorder. Bipolar disorder is a highly recurrent illness requiring maintenance treatment with mood stabilizing medications to decrease the risk of recurrent mood episodes. Preferred medications for bipolar maintenance treatment include lithium, the anticonvulsant valproate and lamotrigine, and the second generation antipsychotic quetiapine. Bupropion, a norepinephrine dopamine reuptake inhibitor, and paroxetine, a selective serotonin reuptake inhibitor, are antidepressants that have the potential to precipitate manic episodes. Now, antidepressant monotherapy should be avoided in bipolar maintenance treatment due to the risk of mood destabilization. Chlorpromazine and haloperidol are first-generation antipsychotics used in the treatment of schizophrenia. Now, first-generation antipsychotics may be used in combination with lithium or valproate for the treatment of severe mania, but are not used as a monotherapy for maintenance treatment of bipolar. Lorazepam is a benzodiazepine that can be used as an adjunct to mood stabilizers in the treatment of acute mania. It is not recommended for maintenance treatment. Now, let's do one more question here. So, which of the following medications will be most helpful for long-term treatment of this patient's psychiatric condition as well as its seizure disorder? So, the person is also having a seizure disorder. Let's go through the question once. A 34-year-old man is brought to the emergency department by his wife after she found him running around the yard in his underwear shouting, "I'm going to change the world." She reports that he has a lot of energy despite hardly sleeping over the past 7 days, and that he recently quit his job to write a 500-page novel that he says explains everything about the universe. The patient's history is significant for epilepsy with generalized seizures since childhood and a psychiatric hospitalization a year ago for a major depressive episode. Family history is significant for alcoholism and hypertension in his father and schizophrenia in his grandmother. Now, which of the following medication will be most helpful in the long-term treatment for this patient's psychiatric condition as well as seizure disorder? Aripiprazole, citalopram, levetiracetam, lithium, lorazepam, phenytoin, or valproate. Now integrate everything, psychotic as well as the seizure disorder. So this patient's history of major depression along with his current manic symptoms indicate a diagnosis of bipolar disorder. Valproate is used as an anticonvulsant and mood stabilizer, which blocks the voltage-gated sodium channels and enhances the availability of GABA. As a mood stabilizer, it is used in acute mania and maintenance treatment of bipolar disorder. Now, as an anticonvulsant, it is effectively can treat absence myoclonic and generalized tonic-clonic seizures. So a variety of seizures can be treated. It is a drug of choice for myoclonic seizures and a second-line agent for absence seizure. Now, other anticonvulsants which can be used as mood stabilizers include carbamazepine and lamotrigine. Now, carbamazepine is a CYP450 inducer that can cause lower levels of concomitant medications. Now, lamotrigine is associated with skin rash, which rarely can progress to life-threatening mucocutaneous reactions. We have one more question here. Which of the following is the most likely diagnosis for this patient? A 28-year-old woman presents to a mental health clinic, reporting recurrent periods of mood instability over the past 2 years. Now, during these episodes, she experiences fluctuations between the periods of elevated mood, increased energy, and decreased need for sleep, followed by periods of low mood, fatigue, and hypersomnia. Now, however, the mood fluctuations are not severe enough to meet the criteria for a manic or a major depressive episode. Now, the patient's daily functioning is affected, but she has not experienced any psychotic symptoms. What is the most likely diagnosis for this patient? Major depressive disorder, bipolar I disorder, bipolar II disorder, cyclothymic disorder, persistent depressive disorder. Now, this is question I have only kept you to let you know how the cyclothymic disorder question may be presented in your examination. So the recurrent periods of mood stability, mood instability, alternating between this hypomanic and depressive episodes, lasting for at least 2 years without meeting the criteria of manic or major depressive episodes are indicative of cyclothymic disorder, which represents a chronic and a milder form of bipolar disorder. Thank you for watching. Keep studying.